Welcome to the 1760 sessions, where I talk to founders and clinical leaders building systems that change how healthcare actually works. I'm Harry from 1760 Strategic AI, and today I'm joined by Dr. Jeanine Maguire, co-founder and president of PAWSIC, the Post-Acute Wound and Skin Integrity Council. Jeanine is a physical therapist and a board-certified wound specialist who spent over two decades building and scaling interdisciplinary wound programs across more than 500 post-acute facilities. She recently completed a Harvard certificate in AI implementation in healthcare, and she co-authored a 2026 paper with a striking central claim that a country's amputation rate is not a clinical accident, it's a structural verdict on its entire health system. That's the thread I wanted to pull on today. Jeanine, thank you very much for being here.
Thank you, Harry, for that really wonderful introduction, and thank you for having me on.
No worries at all. It was a bit of a lengthy intro, and I just want to make
Yeah,
sure that I got everything right and I didn't miss anything at all.
you did. I just want to put one shout out for my co-author and colleague, Dr. Mohammed Baydar, who wrote that article with me.
Okay, awesome. So, what I wanted to kick off with, I know we had a prequel and we spoke about this. Most people think of wound care as a plaster on a scraped knee. For example, I did at the start, and you defined it as something completely different, the end state of failed chronic disease management. So, before we go anywhere else, tell me what you actually mean by that.
Thank you for that really important question. One of the questions I dread most when I'm outside of my work life is, so what do you do for a living? Because the moment I say wound care, you see this blank expression. And what? And so most people do indeed think about the cuts and the scrapes that we have had when we were a child or that we see on our kids that heal pretty well, no matter, what Band-Aid you stick on it. What I'm talking about is a problem that is around 40 million people worldwide, 10 million people in the US. And these are chronic wounds. And these wounds happen, as you stated, they're the physical manifestation of compounding chronic disease. They happen from the inside out. These are the result of unmanaged blood glucose with diabetes and peripheral arterial disease, heart disease, cancer, and so on and so forth. So these are not problems that can be fixed with the Band-Aid. These are problems that require a systemic approach, both internally and externally.
Okay. So what I want you to do from here then is
Yeah.
take me back to the beginning. You said that if someone had told you your teenage self you'd end up here, you'd never have believed them. What happened in your family that set you on this path?
Yeah, thank you. Yes, never in a million years I would have that same blank expression of, what? Wound care? So when I was a teen, my father was in his 30s and he had a traumatic brain injury from, it was first, he was a helicopter pilot, and then the next morning he blacked out on his motorcycle. So it was a terrible traumatic brain injury. He ended up comatose. And what happened from that, it really destroyed our whole family.
Yeah.
Not just, it wasn't the head injury necessarily, because he had amazing rehabilitation, but what was so difficult for all of us is we experienced the healthcare system. And from that experience, I recognized I wanted to do something to make that better. And initially, I thought that was becoming a therapist, which I love. I am a PT, as you said, by background, and that means a lot to me and who I am as a human being. But as I got into healthcare in the hospital setting as a physical therapist, I realized that wasn't the system change I was looking for. I wanted something a little bit different. And luckily, as a physical therapist, we get to do internships. So you get to experience different settings, different experiences. And what I began to recognize was there was a common denominator when I did an internship and worked with patients that had strokes or that had different types of cardiac disease. They were in ICU or CCU. They were in the burn unit. The common denominator is the ones that were really struggling had these chronic wounds. And so luckily, I was able to do an internship as a PT in wound care. And it became obvious to me that this was where I was meant to be. So that became my purpose. I learned everything I could about chronic wound management,
Yeah.
about a team approach, and realized that the wound, as I said, is, the physical manifestation of chronic disease, but it's also physical manifestation of the external when the systems aren't working either. And so for 30 years, I've been working in wound care in different settings, coming to understand what I do now around system change.
Yeah, and I love that you tried traditional therapy, stroke rehab, burn units, and kept noticing the same thing, that there was kind of one common denominator, and that was wounds. Um, when did wounds become the common denominator in all of this? At what point was that aha moment?
Interestingly, so for 7 years, I worked in the acute care space, so hospital space, outpatient space, doing wound management. And in the US, I don't know if it's like this in other countries, but generally the nursing homes don't have a great reputation, particularly with wound care. And I thought, well, let me experience that. So I decided to work in a nursing home, and it was a 1 year plan that I ended up doing for 20 some years. And I fell in love with that space. In that space, you can actually help people through their healing journey. So it's not where you're in a hospital or an outpatient, might only see people a few times and then you hope they get better. But in that space, you're really with people for most of their journey. And you really understood, or I really came to understand and respect the role of the physician, the LPN, the RN, the CNA, the dietitian. It taught me so much around a team approach. And it took me a long time to learn, but then I realized that the only way we can get people to outcomes is really by leveraging our individual expertise, because there's not one discipline that has all that knowledge for these vulnerable people that have these chronic wounds and all these other chronic conditions on top that really led them to that point.
So PAWSIC came out of the back all of this. What did
Yes.
you see in wound care that would made you think this needs a council, not just another clinician doing the work?
So, PulseSick was the idea of myself and a few of my co-founders. So, Sarah Holdenmount, Julie Radovi, Dr. Diane Krasner, Mary Lee Grosso, nurses, physical therapists, operators, and a pharmacist. And what we all recognized working decades in this space for wound management was that there are, number one, amazing organizations already, but they focus on one wound type. So I said there's, 40 million chronic wounds. Of that 40 million, I'm talking about diabetic ulcers, venous leg ulcers, pressure injuries. So there's organizations that focus on just one wound type. Then there's organizations that focus on just one discipline, like the American Physical Therapy Association. They have a wound and electrical stimulation section. Wonderful. But there was no organization that looks at a patient, person, a human with their skin and all their chronic comorbid conditions through a team centered lens, understanding all the regulation and nuance outside the walls of a hospital. And what I experienced over all these years, as well as my colleagues, none of us are academically prepared. This is a global problem. So if you go to med school, there's no track called chronic wound care. And yet, all these people are suffering with it. So, physicians generally learn surgical wounds, surgical site incisions, acute wounds. They're not learning these chronic wounds. And physical therapists, nursing, it depends on where you go to school, but it's generally not enough to support your practice. But we're certainly sued enough. So we have these high expectations. And in the US, wounds are often the second cause of litigation in healthcare, but yet we're not academically prepared. So we felt that we could do better for our patients and for our colleagues.
And look, it feels like the education is out there. It's just not systematically given to you. You have to go outside to search for this kind of education on wounds. And that's part and
Yes.
parcel of what you're trying to do at PAWSIC. You described to me before that this is an avalanche getting bigger faster than the system can respond. For a
Yes.
listener who has never thought about wounds for a second in their life, why is this an avalanche and why now in particular?
The low hanging fruit, the easiest one for anyone outside of healthcare to really hear, and this will resonate, I think, with you and probably most of your listeners, is diabetes. So, most of us know diabetes. Most of us know somebody or have diabetes. So, that's a very common chronic condition that's escalating. Would you agree with that? So, there's a large percentage of people with diabetes who would develop a diabetic foot ulcer. That's one of these chronic ulcers. And to give that some context, there's one amputation from a diabetic foot ulcer every 30
Wow.
seconds. And that is increasing, it's not decreasing. And so this is a global problem. And 85% of those amputations are preventable if we could have prevented that wound or if we could have healed that wound before it got to that level. And even worse, after that amputation, the risk of subsequent amputation on the other leg is very high and mortality is very high. In fact, it's actually worse than many treatable cancers. And so we all are afraid of cancer. We all know about that. But yet, when you say chronic wound to most people, they're not really sure yet what that means.
This loops in quite well with what you told me before. You talk about us living longer lifespans, but not longer health spans. Um, so, can you? I appreciate you've probably touched on some of this already, but walk me through how compounding chronic disease, diabetes, vascular disease, the medications that manage them end in a chronic wound.
Thank you. So, because a lot of these chronic wounds occur really from the inside out and they're the result of the chronic disease, think about for a moment if you have heart disease and you don't have enough blood, you have atherosclerosis, right? So your arteries are clogged, you can't get enough blood to nourish the end of your arteries, your toes, your feet. And let's say you develop that wound. There's no magical band aid,
Yeah.
no magical treatment you can stick on that wound if you can't restore the blood flow. And so these things are all connected. Right now, a lot in the industry is focused on all these treatments, which are helpful, but they will only work if that person is nutritionally sound. So we have to look at the food that's going into their mouth, like with any other chronic disease. It's only going to work if they have balance. So we still need to look at how much sleep are they getting? What is the mental health of that individual?
Yeah.
Because if the mental health is not good, it increases your cortisol, then it keeps you in an inflammatory response, then your wounds can't heal. So often we're so focused on the treatment on top of the wound, we're not working with the right team members to dive deeper to get this person to a real state of healing.
Look, yeah, what I'm hearing is that, like, it's fairly obvious that everything's connected, but why
Mm,
are we only just finding out about it now? Why has this not been dived into before? I know you've written a paper on it. I just don't understand how this hasn't become to light before, and this is more important now than ever because I think I spoke
yeah.
before about a previous client of mine, that connects the body and mind when it comes to how you're feeling in general. And I feel like there's this mismatched
Yeah.
information that's been out there for years that the body and mind aren't connected.
That's a difficult question. I think in one hand, because as you just said, we are experiencing longer lifespan, but not necessarily health span. So now that we're living longer, we're experiencing some more of these physical manifestations of living longer with chronic disease. So I do think that that is a major reason why. The other thing is the evidence is still coming out. What I did learn in PT school, I was lucky. I did have a good curriculum for chronic wounds. The way in which I see a wound is it is a musculoskeletal injury that you can see. So I was lucky in that respect. But I will tell you this, I was in school 30 years ago. What I learned then for chronic wounds is completely wrong and different now with the evidence. And so the evidence is coming out at us full speed. It's almost impossible to absorb all of that information unless you're focused on it. So I am focused on wound care. I have this one tunnel vision area that, leads to all other halo effect for the human and for the system. But I'm very lucky that I get to focus on just one area of practice. But another reason why people don't know is oftentimes there's still a misperception that a wound is caused from medical error. And sometimes that's true, right? A bed sore, a pressure injury, pressure ulcer. Years ago, we thought that that was a nurse's fault. We thought it was all from lack of turning and repositioning. Now we know more that it's more a systemic issue as well. You have to look at nutrition and skin health and hydration and all these other factors. But the point is oftentimes these wounds were looked at as who caused this wound on my mom or dad? It was a problem that maybe somebody else caused rather than an internal response of chronic disease. That's one thing. The second thing is you don't see the heart with heart disease. You don't see the brain with dementia. you see a chronic wound. And I'm sorry, I've been looking at them for 30 years and it
Yeah.
still hurts when you look at. And if it's on somebody you love, that really hurts. And so I would argue that wounds have so much more emotion for people than anything else. So these are hard conversations to have with families about, especially their parents.
I think it's that visibleness that kind of is the shock and awe. And like it happened to yourself, it was probably a horrifying moment to see this. So
Yes.
there's something else I wanted to talk about, and that
Yeah.
is your paper with Dr. Mohammed Bader
Yeah.
makes the case that amputation rates should sit alongside maternal morality as a proxy for health system performance. So I
Mhm.
find the paradox in it fascinating that both the most resource constrained systems and the highest spending one, the US carry the heaviest amputation burden
Yeah.
for completely different structural reasons. Can you kind of unpack that for me?
Absolutely. Yeah, that article, that research was so interesting to do and to really absorb. And it does make you think differently about systems at a much larger level. But look, at the end of the day, we know from the research that amputations are 85% preventable, diabetic foot amputations. And so the question is, well, why? And what are we missing? And of course, you have internal issues, intrinsic issues of that individual where there needs to be some lifestyle changes, but that's not always possible. And that's where the system can really help. So we can tell people, well, you got to eat healthy. But are we inquiring, what does that mean? Do they understand what healthy eating actually means to them in context of their disease management? Can they afford the food and do they have access to the food? And so it's going deeper to understand the system around them. So not just the health system, but the system and the communities in which they're in. And then the health system. How quickly are we able to get that vascular consultation? Can the patient drive themselves to that vascular consultation? How quickly and how well are the teams all working together? And the first physician that they see, do they recognize that this little tiny wound on the bottom of their foot could be that subsequent amputation in no time? So do they understand that this is a really serious issue? So the problem is at all different levels. So there's a lot of similarities there. The problem is education with all different professionals, the ability of the system to pull us together where AI could really make a difference there, making sure that we don't have focus on just topical treatment, but restoring vascular blood flow, correcting nutrition, stabilizing blood glucose, and so on and so forth. But then also the systems and the community of which individuals reside make a significant difference as well. Only 1 in every 8 people can actually navigate our healthcare system and understand what they're supposed to do.
Yeah.
But yet we continue to say, I don't know why they don't do it. They're non-compliant. And we haven't dove a little deeper to understand what are the real barriers preventing people from not getting an amputation, similar to maternal death rates.
So if amputation rate were adopted as a universal benchmark, the way maternal morality is, what do you think would actually change then?
I think what would change anytime there is a focus and a measure on something, there's certainly going to be some incentive for systems to work together. So now that we're in the era of AI, there's more opportunity more than ever to really help systems bring together the right people, the right physician, the right vascular, right podiatrist, right physical therapist, right dietitian, the right person at the right time to make sure we're providing that patient the right information in their language at their reading level. And then we're also addressing social determinants to make sure that they can do those recommendations or address the barriers. But to your point, why would that change? I think that would change just like any of the other quality measures we put focus on. You start to see the systems improve in order to have usually some financial incentive by improving.
Okay. But one of your core arguments is that no single discipline owns this problem, not one physician, not one nurse, not one therapist.
Yeah.
What has the system kept trying to solve it? Well, why has the system kept trying to solve it in a single bucket, do you think?
I think I'm going to answer a different question to that. I just want to say that you brought up a really important problem. The real issue there is that wound care is not a specialty. It needs to be a specialty. It needs to be something that physicians, providers are required to have specialization in, credentialed in. There are indeed credentialed certifications, but we need more. We need one specialized body for this to really own it and to help pull together the team. I think that wounds are often getting lost in the mix, and the end result is that amputation. So we need ownership of this
Okay.
at a leadership level.
And your dissertation built a framework for evaluating a facility's wound program. When you walk
Yeah.
into a nursing home that knows it has a wound problem, what are you actually going to look for first then?
Yeah, that's a great question. So, PAWSIC has a process improvement program, and what that program does is it teaches teams how to assess their program. So, if I were walking in, let's say you wanted me to evaluate your nursing home, the first thing I do when I'm walking around and talking with people is I'm looking at if they're non ambulatory, I'm looking at their wheelchairs. Do they have a pressure redistributing surface on their wheelchair? I'm going in and chatting with them at bedside. I'm looking at their mattresses. Are those mattresses memory foam, high specs?
Yeah.
I'm looking at the mobility. Do we have people up and helping people walk around? Is it a culture of mobility or a culture of safety? You have to have that happy balance because we need to try to inspire people to get up and move around. That's good for all aspects of human life. And so the first thing I do is just walk around and get a sense of the culture and of the products that are being used. Then I like to get a sense of what are your wound rounds? And so in a high functioning facility, they'll have team wound rounds. And team wound rounds mean that once a week, you have a provider at bedside, the nurse, the therapist, and they're engaging with the patient. And the best of the best will invite a family member on wound rounds day as well.
Okay.
And so they can be part of the team. So those are the things that I'm looking for to feel like they have a really high functioning facility. Now, what I also see and what I experienced is I look for a culture of transparency. I look to see that they're doing things like imaging. Imaging is wounds are one of the few things that an image will help a wound specialist identify wound type. It's part of the assessment. And so imaging can bring a wound specialist to bedside from anywhere in the world. And so I look for that culture of transparency as well. That's very telling. A lot of facilities are afraid of bringing in imaging or wound photos, but the reality is families are taking pictures anyway, so you really should be transparent about your program and start to bring in technology to improve it.
Okay. So there's lots I'm hearing here, and it's having everyone involved. It's like we've spoken about this. One point I didn't hear before was, having the family member involved because it's important
Yeah.
they're educated on the piece as well as the patient is as well, and everyone around them. Um,
Yes.
Look, you mentioned to me before you scaled a wound program across roughly 500 facilities
Mhm,
for 22 years. What
mhm.
doing it at that scale teach you that you would have never learned in one clinic? Do you think?
That there's no one size solution that's gonna fit all. So every wound team looked and acted differently based on the culture of that community, based on their staffing, based on the patients and their wound types. And so facilities have to have that autonomy to figure out with their patient and the families what's going to work best for that facility to build that program. But the table stakes are always the same.
Yeah.
Making sure you have like the basics, like a training program that's ongoing for all of your staff, including your nursing assistants. They're the people that see wounds and skin every single day. And also the culture of transparency and no fear. Those CNAs should feel rewarded for reporting issues, not afraid for their position. And so culture is important. Your bed surfaces are important. Your seating surfaces are important. The education and a culture of mobility. Those are the table stakes. And then how you do the rest, according to policy, according to your state regs, they can be shaped differently, center to center to center.
Okay, so like every clinic I can imagine you deal with is completely different and a
Mhm.
different task at hand. Having dealt with 500 in your time. So I want to talk about PAWSIC as well, because we haven't had a chance to dive into that so much. So let's talk about how it actually works because the model is fairly unusual. It's free for everyone with
Yes.
dues only for the professionals who sit on the council. Why did you draw the line there?
So with PAWSIC, what we bring to the world is education for every single discipline
Yeah.
and patients and family. And what we also recognize is that the people who are actually seeing our patients with wounds, all the people with wounds, of course, they're wound specialists, but the wound specialists have usually higher education in this area. The majority of people that are seeing them at earlier stages, we're talking the primary care physicians. They are not wound certified. And we're talking urgent cares and the pharmacists. People will go to the pharmacy and say, I have this wound. Which bandage should I pick from that aisle? So we didn't have this expectation that these individuals would want to pay dues to be part of PAWSIC, to access education that's vital to our vision of changing the world for patients with wounds.
Yeah.
So we wanted to remove that barrier, a system change. So initially we were not free for everybody, and now we are. We wanted to make sure every patient, every family member, every CNA, every PCP and pharmacist could access this material to change their practice, to incorporate wound management into their practice. And so, yes, so we are free for everybody. And we do have the premium level, as you mentioned. That's for people like myself. They want to focus their career on wound management. They want to take all the classes, all the things, get all the credits, and they want to participate in being part of the change on our different committees and shared interest groups.
Yeah.
So that's dues, and that's $12.50 a month. We wanted to make it low enough that it wouldn't be a barrier, but enough that it would contribute to keeping our lights on with all the stuff that we do.
The
But at
fine
the end
line.
of the day, what's that?
It's a fine line.
It's a fine line, yeah, and at the end of the day, it's really our sponsorships right now that keep us moving forward. At this point in time, we're all volunteers, and so we all have other jobs as well. And so as we grow, hopefully that will change over time, and we've only been a real thing for 3 years as a 501(c)(6). And in that 3 years, we're now, as of today, up to 800 members. We're in 44 states and 27 countries. So I have a feeling we're doing pretty good. So as we go forward, my ask is even if you've never heard of a chronic wound, just join us and check out some of the free material. It might surprise you and it might make you think a little bit differently about looking at your skin.
Yeah, of course. And look, I love what you said there, not wanting cost to be a barrier, but enough to keep the lights on. And incredible. In a little over 2 years, you've reached 44 states,
Mhm.
27 countries, 800 members
Members,
entirely
yes.
on volunteer effort. And it's clear that wounds are a clear problem across the
Mhm.
US and across globally, really. What's the main reason you've grown a global community with known paid staff with no paid staff, do you think?
We are 100% purpose driven. So every single person on this board of PAWSIC, we have vetted, we've interviewed, and we're almost all the same in the way in which we see the world. We truly are we are inspired to make a difference for people. We all get that wounds are that end physical manifestation of everything else falling apart, and we all want to change that. So it's the right people. We're really lucky. I'm really lucky that I get to work with these people on this board, and it's my favorite thing to do.
I love it, and this is why you're here today. Um, so your advocacy goal is it's bigger than one facility. It's about getting wound and amputation data taken seriously at a system and
Yes.
policy level. What does winning that argument look like over the next few years then?
My hope is that this will take off and have more conversations like this, not just at wound care symposiums, but outside the wound care group, that other groups will begin to take notice that this is a universal problem. Certainly, the economics tell us it's a universal problem. And so, if we could get some policymakers, particularly in the US, obviously that's where I'm from and I have the most experience, but we have all these new payment systems that are now coming out. And there's opportunity right now for policymakers to hear that this could be a metric that, frankly, if you can solve a wound issue, you're going to solve a lot of other issues that got you to that point.
Yep.
So, this is an issue that when you correct for this, a lot of things are going to improve.
All of
And
them.
that's what I want is just to get that voice to policymakers.
Okay. And that's fantastic. And look, I've got a few more topics to go. So if we've got a bit more time, that would be awesome. For anyone
Yes.
listening who works in healthcare, cares for an aging parent, or wants to support the mission, what's the single most useful thing they can do today?
Join us. Join PAWSIC, pawsic.org, PAWSIC.org. Check out the material there. If there's something that you need that's not there, email me. And if you want to participate, let me know that too. But we are growing and building things based on people's needs and recommendations. So join us. That's the single most important thing.
And look, I will include a link to PAWSIC below for everyone to
Thank
see
you.
in the YouTube description. But there's one topic I wanted to touch on, and look, it's amazing. You've just come off of a Harvard certificate in AI implementation in
Yes.
healthcare. What pulled you toward AI specifically, given that your whole philosophy is that this is human work?
Thank you. Well, that's a great question. So, in the last couple years, I had the great privilege of getting to help a startup, Tissue Health Plus, and my role in that was leading a clinical team and creating clinical pathways and working with AI developers to basically label and annotate and create these clinical pathways so users of the app for wound care could get clinical guidance. And so, what we're doing with AI in this respect, whether it's tissue health or other startups, is using AI to enable the human to provide evidence based care. And so it is the human that does the care, but the evidence is coming at us so fast that you having something like this to guide, not only to guide, but also to have the transparency of where is that recommendation coming from? Because right now, if you go to say an urgent care, and this just happened with one of my best friends on my running team. She fell on the trail and hurt her leg and had a big nasty wound. I was not with her that day. She went to urgent care. They had her leave it open to air. And for the wound specialists on this call, you're all cringing right now. So I didn't find out for several weeks when we were on a run, and I said, "How you doing?" She goes, "Good, but this." She pulled up her pant leg, and it was a horrible. Now at this point, it's a few weeks old. It's turning chronic, and only because they said scrub it with betadine and leave it open to air. So these are things that maybe Google says.
Yeah,
These are
yeah.
old wives' tales. These are things we used to do decades ago, but now we know that delays healing, it increases risk of infection, it causes pain, and so on and so forth. And so, you know, um, my point is we need clinical guidance in the hands of every single person that touches a person when it comes to wounds, because no matter where you work, you're inevitably going to see somebody with a wound and you need that clinical guidance at your fingertips. That's why AI. And so I did that certificate program, honestly, to understand what I was doing at a deeper level, to make sure I was doing it right, to make sure that when we're pulling the evidence that I'm recommending as a clinician, that it's the right type of evidence, that we have transparency, explainability. So when somebody says AI, not all AI is the same. You want to make sure as a clinician that whatever you're using for clinical guidance is going to lead you in the right direction. So this is just a tool to enable your practice, but don't assume that it's always the right tool.
Okay, and it just sounds like there's a lot of misdiagnosis about. I've seen figures, that run as high as when I was researching this, as high as 30 to 40%. So technology can genuinely help there, but there's worry that some of the technology will genuinely just be a bit of noise. How do you kind of differentiate here?
I'm still learning that.
Okay.
So that was another reason why I wanted to take that certificate program because, as a wound specialist and with my personality, I want to make sure that when I'm loading in the clinical algorithms, I'm going to tell you everything, even things you don't need. And so you have to find that balance. And that's where working with a team, like anywhere else. So finding the right developers, the right AI engineers to really work with you and then have humans in the loop. It has to be human based design. You have to have humans, physicians in the field trying this stuff out and making sure it makes sense.
So this is my own view, okay, and this is what I preach, and it's why I do what I do, is that AI is 20% of the answer and 80% is the strategy and the system you put behind it.
Love that.
And
Yes.
that comes from humans. Like AI is a fantastic tool to utilize. Unless you're putting the right information into it, that 20% is going to be wrong. And that's such a small
Yes.
number compared to the 80% strategy you're putting behind it. So, where do you see AI helping PAWSIC reach more clinicians and more families, more than a volunteer team ever could on its own, really?
We have several ideas up our sleeve that right now we are looking for additional sponsors or investors to launch. But we have several ideas that we believe we're going to get this information much faster, to patient level, and then bring that patient to the right certified
Yeah.
clinician. And that's all through tech and AI. We're also exploring different areas of AI to deliver education differently, which most people are now exploring as well. But I truly believe, the way you said, if we use it the right way, we will be able to amplify our reach
Yeah.
and make sure that what we're delivering is something that our patients can easily digest and understand.
It's important that education being digestible piece because it's a lot to take in. It's a lot to understand, and it won't just be done at the click of a button and at the drop of a hat. So right now, PAWSIC runs entirely on volunteers, giving their time outside their day jobs. You've said the real goal is to become sustainable enough to employ people and to keep the ship going, essentially.
Yes.
What does that next stage look like for you?
Yes. Well, full disclosure, we have one contractor, Dahlia, who does our website, and when you join, she's the person who's going to make sure you get all the stuff you need. So, Dahlia, I always have to put a shout out to her. Without her, the ship would not continue at all. But outside of Dahlia, you're right. We need to grow this into something sustainable. So, as our board constantly cycles through, because we created this, so we constantly
Yeah.
get fresh blood to the board and fresh ideas, but we definitely need a foundation of leaders that will be able to keep this going forward, regardless of our board transitions. So that's ultimately what I'm working toward, is how can we make POSIC something that continues to grow and support people at a global level.
Okay. And a lot of founders measure success in revenue. What is your North Star metric? The number or the outcome that tells you that this is working?
When we have wounds as an actual metric,
Okay.
amputation rates as an actual metric, when I tell somebody that I do chronic wound care and they go, "Oh, that's fascinating. I've heard of that." That would be a metric. When people actually know that this is a problem for every single human who has skin.
Okay. And look, that is a perfect place to close on. Janine, this has been exactly the conversation I've hoped for. You've taken something most people never even think about and shown it to be a window into whether a health system is actually working. So look, thank you so much for coming on. And this has been incredibly educational. I'm looking forward to sharing all the details about it. Is there anything to add before we part ways?
Just that I appreciate you. Thank you for, enabling my voice to reach a larger audience. And thank you.
Amazing. Thank you very much, Janine.
Thanks, Harry.